Welcome everyone to the video. Today, as an honored guest, we have on high demand in our Facebook group TRT and Hormone Optimization, here with us, Dr. Jeffrey Ruterbusch. Welcome, Jeffrey.
Well, welcome, Stephen. Thanks for having me once again on your excellent podcast. Looking forward to covering some information material, something I've been looking very much forward to share with the group.
Great. Happy to have you. And today we're going to talk about low libido, TRT, erectile dysfunction, and much more, all common men's health issues. Welcome to this channel. I am Dr. Steven de Vos, the lifting dermatologist, and this is my bro science hunting partner, Danny Bossa. If you want to learn more about the most cutting-edge science-based information in the world of hormone optimization, please like and subscribe.
Click the bell button to get notified.
I also invite you to join my other YouTube channel, The Lifting Dermatologist. The link you can find in the description of this video. Can you explain the difference between erectile dysfunction and low libido?
Sure. Usually they go hand in glove. Usually low libido or sex drive will lead to erectile dysfunction, but it can be the other way around too. Sometimes erectile dysfunction can lead a man into having somewhat of a low sex drive because it gets him into an area of performance anxiety. He kind of quashes his appetite. So in the event that he doesn't have to be embarrassed about a poor performance. So yes, I deal with this all the time now in my erectile dysfunction, premature ejaculation, low T clinic.
And are there different causes for low libido versus other causes maybe for erectile dysfunction?
Well, yes. Low libido mostly is caused by low T. In other words, androgens, in particular testosterone, will drive sexual interest. But people don't know this, but in my practice, I'm only able to treat maybe less than 20% of men who come in with erectile dysfunction. Only about 19% are actually improved when I give them testosterone optimization therapy.
Okay. And erectile dysfunction, it can have other causes like vascular problems maybe.
Yes, it's divided up into a neurogenic component, a vascular component, a neurogenic component, and an endocrinological component. But I also throw the fifth cause, one of the most leading causes I see, is pharmacological causes. Medications that I see men on are giving them the major erectile dysfunction issues. Now, the number one risk factor for erectile dysfunction is simply age. As men age, that becomes a more and more of a prevalent issue. But again, I'm not a urologist. I'm a retired sports med doctor. I got a lot of additional training in Europe and in Japan when it comes to sexual health issues. And I got a lot more when I was in the Middle East. So I have a low T clinic where I do a lot of erectile dysfunction. And we'll get into some issues I have and some ways I treat this. I know some of the urologists we have here do this routinely, but I come at it with a different perspective, sports med, preventive medicine side. And again, I've probably treated now, I would say several thousand men with erectile dysfunction or ejaculatory dysfunction. They're both ED, but under the ED issue comes ejaculatory disorders and premature ejaculate.
Okay. And how, if those guys come in and complain about sexual issues in the bedroom, how do you go about that? How do you start working them up?
Well, they do a lot of paperwork. So first of all, it's a very touchy issue. And I didn't know this because I've been around it so long. 40 years, and men are very reluctant to come in and talk about it. So our staff is all male. The science being, or the philosophy is that if a guy walks in or picks up the phone and calls your clinic and there's a sexy female voice there, he may just hang up, Or he walks into the clinic and there's a smoking hot gal at the front desk, he's going to just turn right around and leave. However, some of the more successful clinics in the United States currently are staffed predominantly by women. So go figure. So it can work for the business model or it can work against the business model. Our model is old school. We just have all male staff just in case the guy gets, turned off by walking in and seeing a female. So there's a lot I have to cover here. So a guy comes in, and he fills out paperwork. So I go in and I have to determine if it's erectile dysfunction, premature ejaculation, delayed ejaculation, anorgasmia. Most of my men are older, 50, 60, 70. But I have a gamut of men, Stephen, 18 to 95. Now, you wouldn't think an 18-year-old would have erectile dysfunction. Very, very, very unusual. But that 18-year-old had one of the worst cases of erectile dysfunction I have ever seen. And when we get into some of the therapies, and I have numerous therapies I can discuss, that 18-year-old took all my armamentarium to get him back in the saddle again.
And after anamnesis with the patient, what kind of examinations do you have to do, or patient go?
It's a cursory exam, Steve. Now, obviously, vital signs are done, and one of the things they fill out is obviously a history, go into family history, prostate issues, BPH issues, medications. I mean, most guys come in and they're on, excuse my French, they're on a shit ton of medicine. And many have, probably 80% of my men have diabetes or pre-diabetes. Many are smokers. So the number one killer of erectile function from my many men is diabetes. And a close second would be smoking. A close third to that would be the myriad of medications, in particular, blood pressure medicine. And of those blood pressure medicines, it's usually the beta blockers that put men's penises in the dirt. So I have to do a lot of, so what happens is I look at the patient, they do a shim score, sexual inventory in men. I ask them their erectile hardness, strength, a 0 to 10 scale. 0 is limp, 10 is rock hard. Give me your best number. With and without help, meaning, Viagra and Sas, Levitra, so forth. So I look at those numbers, and then I look at the guy's age and the medications, and I devise a test dose of a trimix or a bimix or a quad mix or a quid mix. So these are intracorporal injections. Yeah, needling the penis. It may sound painful, but it's not. So once I convince the patient, let me go ahead and give them a test dose of a certain medication. And sometimes I can't convince them, but if they do, I'll give them an erection in the office, many of which are very impressed because some of these guys, Stephen, haven't had any type of an erection in decades. So they see that, with these intracorporal injections, that I can give them an erection in the office, but I don't shoot full erection, because many times if I ever shoot them, they have to be in my office for hours as I babysit, 10 rooms with guys with erections, and then I have to give them an antidote, phenylephrine to bring it down. But so I just shoot for a partial erection, and then I gradually ramp that dose up to a take-home that would suit their needs. Some guys want an erection for a half hour. Some guys want 2, 3, 4 hour erection. Depends on their needs. And I control that with the way I mix and match the substances like phentolamine and papaverine and alprostadil, atropine, forskolin. These are things I put in the mixtures. I have like 300 different blends, strengths, you might say, that I can use at my armamentarium. But you know, I preach you lifestyle changes and so forth, and diet and exercise and these things. And I'll do a full blood panel to see what their hormone profile looks like. I can't speak to that same day. It takes a couple of days to get back. Well, once I get the hormone panel back, and I add them, I look at their testosterone and free testosterone, and I look at an Adam score and androgen deficiency in the adult male. There's a 10 questions that pretty much yes or no, and the more significant yeses they answer to, the more likely they have low T. If I marry that up with a blood profile that showed me they have low T, then I can go ahead and talk to them about the pros and cons, mostly pros, of testosterone optimization therapy. That's how I lead into the guys. But again, an erection is a multifactorial, very complex psycho-neuro endocrinological process. And it simply is not resolved by testosterone alone. And I'm telling you, people are amazed at the fact that I can only treat about 19% of men with ED by optimizing their testosterone. And the significant thing about that is that testosterone has to be very low. If it's below 320, I can usually give them much more erectile function by getting the total T above 320. But if those guys are 400 or 500 and still have low T symptoms, very unlikely that just me maximizing or optimizing their testosterone is going to get them back in the saddle again. And many of these guys are disappointed thinking that if I give them testosterone, they're going to have sexual function again. Now remember, there's a difference between libido and erectile function. You don't need sex drive to have an erection. If you did, a little newborn baby male who gets erections all the time, he's not having sex drive. He doesn't have testosterone, does he? So how are these little baby boys getting erections all the time? They're not getting stimulated visually. They sure don't have any testosterone, so you don't need testosterone. Plus, in the old days, read about in Shakespeare's times, they had these eunuchs, chambermaids, guys that they would castrate and put them in guard of the queen. They had no sex drive, but guess what? They could perform sexual intercourse because the queen, when he's the king or whatever the guy, he's off to war or battle, she'd be having fun with the eunuch. This guy's got no drive, but he's able to have erections. So you see the disconnect between testosterone and erectile dysfunction. See, you don't need testosterone to have erections. You do to have libido. But there's a difference between the two.
Yeah, very interesting. And this video, as you can suspect, will be watched by a lot of people interested in testosterone optimization. And we get those questions in our Facebook group all the time. I get these messages, posts online, people saying, well, my levels of testosterone are optimized, but I still suffer from low libido. So what can I do? So what's your answer there?
Yeah, well, also, you'll find that a lot, and you'll find that a man, once I put him on testosterone, his libido will increase for a few weeks, maybe a couple, 3 months, but then he settles back into his low libido phase. The body normalizes. He kind of gets used to that dose. So, every man that comes in, I recommend, I don't care their age, I don't care their erectile dysfunction etiology. I suggest that they get on a low dose PDE5I, like Viagra or tadalafil. Because guess what, Stephen? Research indicates that if I put a man on just standalone low dose, say tadalafil, Cialis, I can increase their testosterone by up to 115 nanograms per deciliter. That one therapy alone. But since erectile dysfunction is the canary in the cave of total body vascular dysfunction, we know that PDE5 I's increase enos in the vasculature of the penis, does not stand to reason that PDE5I will go total body and increase blood flow in every part of the body. So I use it as an anti-aging therapeutic to suggest all my men to get on low dose PDE5I.
What dose is that?
Well, 5 milligrams of Cialis a day is the only medication, PDE5I, that's been approved by the FDA for BPH. Now, granted, a lot of my men come in, they have BPH, so they have symptoms of BPH and they're already on it, or they're not. Plus, the usual doses of Viagra, 50 to 100 milligrams, Cialis, 20 milligrams, Libido, 20 milligrams. But guess what? I have a compounding pharmacy, Stephen, that makes my medicines, my Cialis, 75 milligrams, not 20. My Viagra goes up to 150, not 100. Why? Because most guys come and see me, those medicines are failing them. So I can take 25 up to about 25% of non-responders and make them responders simply by giving a higher dose. Or I can take a non-responder to a Viagra, switch them to a Cialis or Levitra, and I get maybe up to 10% of my non-responders now become responders simply by changing the PDE5I they're on. Now, depends on what you read. Up to between 80 and 98% of non-responders to PDE5Is can be made responders by optimizing their testosterone.
Okay. Are there any other supplements you can recommend men to take, the optimization-minded men, of course, in order to get better libido and erections?
Yes. Yeah, okay, there's a bunch out there that get a lot of hype that aren't really founded. But from my experiences, there's 3 that I've used routinely that give me great results as supplements. All right, you have arginine. And I'm talking 3 to 6 to 9 grams of arginine. Okay. If I combine 3 grams of arginine with 80 milligrams of pycnogenol, write that down. 3 grams of arginine and 80 milligrams of pycnogenol. I can get 80% of my non-responders, PDE5Is, to be responders. And some of these guys, just by that supplement alone, don't even need a PDE5I. All right. And the other thing I found very beneficial is 2 grams of acetyl L-carnitine with 2 grams of propionyl L-carnitine. Again, 2 grams acetyl L-carnitine, 2 grams propionyl L-carnitine. I found that has significantly improved erectile function in men. Now, again, these things may not work overnight. I find that these supplements can take maybe a week or 2 or even several weeks to kick in. But they do work if you give them time and dial your dose upwards.
And how do those work?
The supplements?
Yeah.
Well, again, I'm not a scientist like Scott Howell. I don't do a lot of research on these things. I read the naturopathic journals. I read the functional medicine journals. I speak to guys, other physicians who have been doing this for a long time, and I ask their opinions on what supplements they've used. And then, like years ago, I would suggest it. and when I was in the Navy, treating mainly younger guys, I can't tell you, I had great results with my younger guys in the Navy who had some episodes of ED. If I just gave them, just take some arginine. And they come in and say, "Doc, it works like a charm." So that's mainly anecdotal evidence due from the research I've done in the functional medicine and the naturopathic medicine journals about those supplements. And there's manuals on herbs and so forth. And of course, when I was overseas in Japan and Korea, I learned a lot about how they supplement themselves naturally to enhance male potency. And those were the substances that were used most frequently in places like Okinawa and Japan and Korea. The supplements I just spoke about.
Very interesting. I think a lot of men will be very happy to hear those recommendations from you. So we talked about medication, we talked about supplements. Are there any peptides that can be used for those reasons?
Yes, okay. The one peptide that I've had great success with, especially in my non-responders to either PDE5Is. And remember, if I say PDE5I, I'm talking Viagra, Cialis, Libido, or Ivana. So now many times I can use a trimix or a bimix or a quadmix, intracorporal pharmacology and give them the erection. But a lot of my guys are needle phobes. They don't want to pick a needle in the penis, even though they know it doesn't hurt. There's a certain lack of spontaneity. They have certain disorders. A lot of guys have body habitus, big old booty bellies. They can't see their penis. They're not going to inject themselves. Some guys have Parkinson's or some kind of whatever they got on. They just shaky hands, They can't inject themselves. So there is one peptide out there approved by the FDA for female sexual dysfunction. I think it's called Vyleesi. Also approved for HSDD or something, I think hormonal something deficiency. I don't know, but just think about it as FSD. It's approved for women and with female sexual dysfunction. So just like, think about this, back in the late 90s, when we discovered serendipitously that Viagra, which first came out for a blood pressure medicine, and it fails trials for blood pressure, but when the drug companies were recalling it, many guys weren't sending it back. And the research indicated that, well, hey, it didn't control my blood pressure, but it sure gave me good wood. That's how we discovered the fact that Viagra had the side effect, giving men erections. So the serendipitous finding. So now fast forward to female sexual dysfunction. Vyleesi has been approved by the FDA. It's bremelanotide. Bremelanotide, otherwise known as PT141. It's a melanocorticotropin stimulating agonist. At the melanocorticotropic site in the brain. We don't exactly know how it works. But the good thing about it is that about 80% or greater of now my men who don't respond to PDE5Is, who don't want to inject themselves in the penis, now if they give themselves this small dose, usually 0.5 to 1 milligram, subcutaneous injections in the belly fat, just, subcu, of PT141, greater than 80% of my men that have not responded to any other method are now responding with erections due to that one peptide called bremelanotide or PT141.
Okay, very interesting. Are there any mechanical at-home devices that men can use in order to get these stronger erection or whatever? I saw
Well,
recently on YouTube Jay Campbell with some kind of a rocket on his penis. I don't know what it was, but can you talk about that?
yeah, okay. That's a big market here now. When I was in Korea and the Middle East, we knew about this acoustic wave treatment, you know, low intensity shock wave treatment, okay? Low intensity extracorporeal shock wave therapy. So that was a serendipitous finding too, because we knew as a sports med doc, I was using ultrasound, acoustic waves, to heal many soft tissue injuries, enthesopathies, bursitis, tendinitis, tendinopathies. But somebody decided to direct that ultrasound wand to their penis or to their perineal region, and they got an erection. Much like you can take a little, I mean, not to be perverted, but if you take a handheld vibrator, you strap a vibrator to your hand and put it on your nose, you're going to sneeze. You can take a vibrator of any sort, just bury it to your taint. Guys, you know what the taint is, don't you? Okay. If you put a vibrator on that taint of yours, you're going to most likely get an erection. So this low intensity shock wave treatment is ultrasound acoustic waves guided towards the corpus cavernosum. So one treatment of the shock wave treatment is about 5,000 pulses, 2,000 on each of the corporal bodies, and another 1,000 pulses to the taint region, you know, the region just underneath the scrotum. So that's been found to be very effective for mild to moderate erectile dysfunction. In fact, so effective that Dr. Richard Gaines, a board-certified anesthesiologist, devised this Gaines wave treatment. And basically, it's a storage unit, a storage device that he has put the name Gaines wave on, the same unit. And now Dr. Richard Gaines has opened many clinics, international clinics, just doing ultrasound therapies on men. Now, 2/3 of his techs are females. And I noticed that when Jay had that video, there was a female working on his private. So now that's good actually, but some guys don't want that. But the majority of men will develop a relationship with their female technician. And the result of the acoustic wave device is made better if the man has a bit of a partial erection, believe it or not. So they find by having women doing this and guys getting a partial chub erection that the outcomes are better because the acoustic wave is now being distributed through a water-based medium, you know, blood, the blood engorged penis. So these waves, they go in and they kind of, they knock off, oh, kind of like you see a rusty pipe, you look down it, and you hit it with a hammer, and you see all this rust kind of fall off. Well, it's similar. What happens is we're knocking off little tiny micro plaques on the penile blood vessels. And then what happens is the body will naturally respond to that irritation or injury by bringing in blood flow, white blood cells, and growth factors. You know, platelet growth factors go there, and they will engulf via macrophages the plaque, and then growth factors are emitted in the damaged tissue, and you get an angiogenesis, a neovascularization. Now, there's also a procedure we do called PRP, platelet-rich plasma, where we'll take a man's blood off, you know, their arm here, and take 10 cc's off, and we'll spin it down to pack the red blood cells at the bottom of the test tube, and we'll take off the platelet-rich plasma, PRP. We'll inject that in 5 strategic locations in the penis after I've done a lidocaine penile block. And that's been shown to be very beneficial in and of itself with the growth factors. Well, I'm sorry, let me back up. I lyse the platelet membranes, releasing immediately all the growth factors by putting a little either calcium chloride or calcium gluconate into the PRP and then inject. If you don't do that first, you're going to have a lot of platelets just going to die off. So will the growth factors before they're released. So PRP is a strategically placed biological medicine into the penis to heal from within. Now, there's a synergistic effect. Synergism, 1 + 1 = 3. If I do the wave first, causing micro trauma, micro damage to the vasculature, and then I do the PRP, and what happens then is the platelets that are now ruptured, all the growth factors see this damaged tissue and immediately migrate to the damaged tissue and work better. So I get a better result with erectile dysfunction and angiogenesis by doing both PRP and the wave together. But if a patient does schedule them together, I always do the wave first.
Oh, that's very interesting. Thanks a lot. Okay, is there anything more you wanted to add to all this regarding these erectile dysfunction and low libido issues, Jeffrey?
Well, I mentioned to you how disappointing it is that I can not heal every man's erectile function by giving them testosterone. But I do want to open a can of worms here because in our group here, I think the big elephant in the room is men on TOT who don't want to admit that either their sexual function, their erectile function, has been fixed, or it was fixed and then it diminished, or then it kind of normalized again and tapered off. And so my point to you, Stephen, and I think there's a lot of men out there that are on TOT that aren't admitting openly that it's not fixing their erectile functions, giving them some libido back, but they're disappointed that the erectile function is not working. And so I'd be willing to bet that if you took a straw poll of every man that was straightforward and was actually open about this, that a lot of men on testosterone are not reaching the sexual function that they'd like to be at, or certainly weren't at when they were 18 to 25. And because, Steve, I've seen thousands of men now, and one of the most common things they tell me, or I hear, is that, damn, okay, I got that libido back again, but it's just not working like it used to. So if I have a man that, that has that, well, then I'll ask him, say, okay, let's look at your free testosterone, look at your thyroid function, look at your DHEA. Are you resting well? Are you attracted to your mate? These guys don't want to tell me this because if I dig into it, I'll find out hey, I only have this problem with my wife. She's a real bitch, or she's a cow, or whatever they say. They tell me this all the time. But if I step outside the marriage, or I have an affair, man, no problem, doc, it's right there. Well, that's not a me issue; it's a them issue. I mean, that's their relationship, So I have to tell, actually, guys, please level with me if this is, to have libido and erectile function, no matter what I do with you, it's got to be something inside that marriage that you want to be intimate with, because we're visual people. If your wife has gone to seed, and trust me, a lot of these guys who come and see me, half of them haven't even seen their penises in decades. You see my point? So I look at them and I don't say anything, but I'm thinking, well, maybe your wife doesn't want to have sex with you anymore. So that's the whole dynamic that I don't really get into, but it's so much goes on behind closed doors. If I fix a man's sexual function, I cannot tell you the number of times they come back to me, either want a refund, and I say, what's wrong? Doc, my wife doesn't want to have sex with me. Or doc, she thinks that I'm going to take this newfound potency and take it outside the marriage. Or, you know, they become so used to no passion, but compassion, it just disrupts the dynamic of their marriage, what they've been used to. So you got to be careful of fixing these guys. Now, I know, you know, Angie and Keith will bring in the wife and fix her too. I don't have an ability in my men's health clinic. Obviously, in my other practice, you know, kicks a mass, I can address both issues. But that's the biggest issue I have is the disappointment I've had with optimizing men and realizing that I haven't optimized their sexual function. I've given them libido back, but their erections still aren't what they used to be. Now, again, with the PRP and the wave, I can develop the angiogenesis and can make their blood flow youthful again. But one of the things I want to bring up too is that you've heard of BPC 157, body protective compound 157.
Yeah.
I've used that in sports medicine recently to inject into joints, cartilaginous spaces, to heal musculoskeletal injuries. Right? Okay. I was reading some research that says that stuff is tremendous in neovascularization, angiogenesis. My theory, and I would like to try injecting BPC 157 into a man's corporal bodies, just like I do bimixes or trimixes, and see if that works to create, you know, new blood flow as it does in other tissue. I just haven't found a willing patient that said, hey, doc, let me be the first. But think about that. I think there's a market for BPC 157 in ED.
Okay, this was a very informative, great lecture. Thank you, Dr. Jeffrey Ruterbusch. And if men would want to work with your clinic, how can they reach you?
Oh, well, you know, you just go to kicksomemassop.com. Kicksomemassop, that's 3 S's, I'm sorry. Kicksomemass with 3 S's, op.com. That's where I'm able to treat men and women and whole men, because that's why I can look at other things like pregnenolone, DHEA, thyroid function. In my other clinic, Men's Health LTD, I just can look at, you know, corporate just had me look at testosterone. And again, to treat the whole man, even though I can help many men out with the trimixes and bimixes and some pot, I'm not able to treat really the whole man at Men's Health LTD, because I don't look at thyroid function there or pregnenolone or DHEA, and I definitely can't help the other part of the marriage. I can't help the female in regards to Men's Health LTD, but at kicksomemassop.com, I'm able to treat every aspect of our hormone milieu, address lifestyle changes, set nutritional protocols, get them involved in a health promotion and wellness program at my gym. I own a 5,000 square foot fitness studio where I do bariatrics, I do IV nutritional therapies. Just added benefits that I have. I can treat the whole person there. So that's how you get a hold of me. www.kicksomemass with 3 S's, I'm sorry, .op, I'm sorry, op.com. www.kicksomemassop.com. OP is for Orange Park. So listen, it's been a real pleasure. I hope you guys have learned something from this, my 30 plus years of dealing with hormones, and especially now with dealing with 10,000 guys with erectile dysfunction. Every guy's got a different story. It's a complex problem, and it just takes a man with the fortitude just to make a phone call and come on in. I didn't know it was so difficult for men to come in. A lot of guys call up, they make appointments, they just either don't show up or they just don't even call up. I think they have either their spouse or lover says, "Oh, you don't need to go see them," or lays a guilt trip on them or something. You know, I will say this, another big elephant in the room is one of the reasons I find now, especially to my younger guys with ED, is they're addicted to porn. Okay, serious. I mean, pornography is prevalent in the social media. You go to these computers, you guys are addicted to pornography. So I go into that history too to determine if it's a psychogenic aspect versus, you know, neurogenic aspect, which happens to my prostatectomy guys who come in, they've had nerve damage. Instantly they have ED because they got nerve damage. But most of the guys have, you know, it's vasculogenic because they're older, and they have you know, poor blood flow because it's simply an aging process. But that's why the acoustic wave, ultrasound, and the PRP are actually therapeutic, because I can create younger blood flow with those means. The ICP, or intracorporeal pharmacology, that doesn't get to the root cause. It just circumvents everything. Well, over, you know, some years of being on the injectables, well, eventually, like any other medication, there's going to be tachyphylaxis, and then a man needs stronger meds to the point where nothing's working anymore, and then he's going to have to go see a urologist to have a, you know, implant.
Okay. Thank you so much. And
You're welcome. Thank you.
see you in the next video.
You got it.